Hey, good afternoon, everybody, and welcome to Grand Rounds. Today, it's my pleasure to introduce co-presenters. Rochelle Mccabe is an advanced registered nurse practitioner, and she works collaboratively with Dr. Todd Eibes, who is a fellow of the American College of Surgeons, specializing in bariatric surgery. They very kindly have accepted our invitation today to provide us with a review of an epidemic that's not COVID. And they are going to be speaking on the epidemic of obesity. And please join me in welcoming Rochelle Mccabe and Todd Eibes.
Hello there. I am Rochelle Mccabe. The only disclosure I have, we are employees of Iowa Weight Loss Specialists with Iowa Specialty Hospitals and Clinics. And so as far as Iowa Weight Loss Specialists here in Ames, we are located in Mary Greeley on the second floor below acute rehab next to the sleep lab. There is no formal referral needed. Patients can call our main number. I left some brochures and business cards up at the back table. Our main number is 515-327-2000. Or they can go online at just iowaweightloss.com and they can get started with paperwork that way. It's pretty easy. We do prescribe weight loss medications and we offer the option of surgery. We offer multidisciplinary approach with medical providers. We have dietitians, mental health counselors on staff. We have health coaching, and those are all available for both medical and surgical patients. Patients can be seen at any of our locations for medical weight loss and pre- and post-surgical management. We do offer telehealth as an option and see patients across Iowa. I even see some out of state. Our main office is located in Des Moines, and then we have additional locations in Ames, Fort Dodge, Belmont, and Garner, and they all offer all of the amenities of the West Des Moines Clinic. So I am Rochelle Mccabe. I am the medical weight loss provider here in Ames. I received my doctoral family nurse practitioner degree from the University of Iowa. I completed my DNP project on how patients with obesity are cared for in primary care and realized there is a significant need for further education and advocacy for obesity as a disease. I will review medical weight loss and provide some practice pearls for primary care, and then I'll turn it over to Dr. Eibes to focus on surgery to treat obesity and associated metabolic disorders. Obesity is a complex, multifactorial chronic disease. Historically, we tried to control cholesterol, hypertension, and diabetes with diet and exercise. The advancement of medications for these diseases had a drastic impact on treatment. Obesity is no different. Most people can absolutely change nutrition and activity, but this won't necessarily translate to weight loss, and almost certainly not weight loss to the extent that an individual becomes normal weight. Simply eating less and exercising more is based on a simplistic model of energy balance that ignores complex metabolic pathways that regulate metabolism and fat storage. Stigma and bias are serious barriers to care. Patients with overweight or obesity may avoid seeking care due to feeling ashamed or embarrassed. Evidence-based treatment is available, but significantly underutilized. Insurance coverage for anti-obesity medications can be challenging in Iowa. Those who do cover them often have a very difficult prior authorization process. Advocating on behalf of patients is needed to increase access to medications and treatment options. Writing a personal letter to the insurance company, employer plan, and even the lawmakers can be helpful. Specialized treatment is needed to meet the array of needs patients with obesity face. Every patient is unique. The biology of why some people may store excess weight needs to be addressed on an individualized basis. Primary care providers have a lot to address in a short amount of time when seeing patients. Addressing overweight and obesity can be quite time-consuming amongst all the other comorbid conditions and concerns a patient might have. A referral for medical weight loss can be beneficial for these patients as we focus specifically on this concern and have an entire team available for support. Medical weight loss teams are well-versed in caring for people suffering from obesity and aware of the stigma surrounding these patients. Stigma-reducing strategies are incorporated throughout the clinic in treatment of all patients. We have a SICA scale and calorimetry available on site. We encourage regular follow-up. Our program also offers individual health coaching and support groups for patients who prefer additional support. Providers on the medical weight loss team offer evaluation for underlying endocrine, hormonal, and mental health disorders such as hypothyroidism, Cushing's disease, polycystic ovarian syndrome, or binge eating disorder, for examples. Evaluation of comorbid conditions such as hypertension, diabetes, obstructive sleep apnea, reflux, hyperlipidemia, depression, and anxiety may be necessary. Personal and genetic predisposition to difficulties with weight control are considered. Assessment generally includes the use of a body composition scale to determine each patient's specific muscle mass and excess body weight. Calorimetry may be used to accurately measure metabolism and daily energy needs. Thorough assessment of nutrition, the patient's daily nutritional needs, and dietary counseling is essential. Evaluating a patient's lifestyle and adjusting approaches to meet specific needs is necessary for success. A thorough physical activity assessment may guide referrals for additional support. Medication management plays an important role in medical weight loss as well. Some patients take medications that may cause weight gain, so alternatives can be suggested. Surgery is a great option for some patients. Our team coaches patients pre- and post-surgery to work on behaviors for success. These include monitoring nutrient intake, eating slowly, chewing well, separating beverages from foods to allow proper digestion, taking supplements, adequate physical activity, and managing mental health. When noting an elevated BMI, it's easy to jump to conclusions. First, look at your patient. If you don't have access to body composition measurement, do they look muscular or are they generally healthy? Ask if they have any concerns about their weight. Don't assume your patient isn't eating a healthy diet. Ask open-ended questions before jumping to conclusions. For example, I often find patients who are trying to lose weight are making healthy choices, but maybe over-consuming nutrient-dense foods such as nuts. Ask, what do you eat in a typical day, starting with breakfast? Consider genetics. Ask about family members and when weight gain patterns began over their lifespan. Consider socioeconomic status. Ask about their job, their routine, stress, finances. Do they have access to healthy foods? Review the current medication list. Are they taking medications that cause weight gain? Has the patient been evaluated for underlying conditions such as hypothyroidism? The issue might also be behavioral. Ask, what do you feel like you struggle with? How active are you throughout the day? Do you wake up in the night to eat? Do you feel a lack of control over your eating? Do you vomit or avoid eating for extended periods of time after overeating? Obvious disordered eating patterns may be identified for which a referral to mental health is warranted. Medical weight loss teams are an evidence-based interdisciplinary approach to obesity management. Teams may consist of nurse practitioners, physicians, assistants, dietitians, fitness professionals, and mental health providers specializing in obesity. When weight loss surgery is an option, a bariatric surgeon consults with those patients. Nurses, program coordinators, and insurance specialists are essential in navigating patient care. Mental health therapists see patients for individual counseling and group therapy and may lead support groups. Our program offers health coaching for additional support for patients wanting more accountability. I often refer patients with physical limitations to physical therapy to establish a modified exercise routine. I've referred several patients to aquatic therapy at Medical Arts, and that has been a great option for them. I also make regular referrals to address sleep, endocrine, orthopedic, and GI issues that might come up. Obviously, nutrition is an important aspect of the treatment plan. The physiology driving hunger, satiety, and cravings, along with practical approaches to manage these, are reviewed with patients. If a patient is wanting to follow a diet, the first approach is balanced meals, including a lean protein source, fruits and vegetables, and healthy starch choices at meals. Patients may be directed to review myplate.gov for a guidance. I often will recommend maybe the Mediterranean diet as a good guideline. We do not recommend eliminating food groups such as no meat, no dairy, or no fruit, for example, unless there's an intolerance or an allergy. We certainly recommend limiting processed foods and dining out. Frozen meals have come a long way in recent years and may offer a quick, healthy option. We teach intuitive eating behaviors such as noting hunger and satiety cues, eating slowly, chewing well, and stopping when full. Portion sizes and daily caloric needs are reviewed. We do offer metabolism testing via calorimetry to help estimate daily caloric needs. Food journal apps are pretty accurate and easy to implement. We do recommend a real food approach, however, meal replacements are not necessarily bad. There are a lot of programs who highly utilize them, which can be helpful at first for patients who have very little knowledge on nutrition, but ultimately we want to teach them how to eat a healthy, balanced diet without relying on supplements alone. Mental health disorders can be a significant barrier for some patients. Mental health referrals are often placed when disordered eating is identified. Binge eating is a disorder characterized by bouts of emotionally driven overeating. Patients often describe a lack of control, altered awareness, and inability to stop during these episodes. Guilt and disgust are often felt. I will often treat binge eating disorder with medication and refer to therapy. Lisdexamfetamine is FDA approved for binge eating disorder, but Medicaid and some insurance companies require a psychiatric provider to diagnose and prescribe it. Bulimia is associated with binging and purging patterns. Anorexia involves avoidance of eating. With sleep-related eating disorder, SRED, the patient eats in the night as if sleepwalking, completely unaware it's happened. They may wake to find evidence such as food wrappers. With night eating syndrome, NES, the patient is fully awake and aware, expressing they wake in the night and cannot get back to sleep without eating. Anxiety, depression, and stress can also shape eating habits. ADHD is often associated with binge eating disorder, and patients may cope with snacking or eating. OCD, a history of trauma, and substance abuse have strong links to disordered eating. Yep, there we go. Okay. Weight gain promoting medications. When prescribing medications, please consider the weight gain profile for patients at risk for overweight or obesity. Drugs with a weight gain profile often include certain beta blockers and calcium channel blockers, anti-diabetic medications, hormonal therapies, anti-seizure medications, antidepressants, mood stabilizers, and some migraine medications. Medications for obesity treatment. The use of weight loss medications may be a helpful tool for some patients to aid in adherence to lifestyle and behavioral choices. An array of medications specifically designed to target different aspects of appetite, hunger, and behavior are used in medical weight loss in conjunction with lifestyle and fitness advice. It is important to understand medications for weight loss are tools. They are generally ineffective on their own without establishing behavior and lifestyle change. Additionally, maintenance use is often necessary with weight regain occurring when medications are stopped. I will review each of these medication components separately, though some of them are only FDA approved for use in certain name brand formulas or in combination drugs, which I will point out as we go. So metformin has a very safe treatment profile, and extended release versions are tolerated well by most patients when carbohydrate intake is controlled. Besides treatment for diabetes is often indicated for PCOS, insulin resistance, and metabolic syndrome. Off-label, it can be prescribed for general metabolic support in aiding weight loss efforts, and some evidence suggests it may target belly fat. It can help mitigate weight gain when prescribed alongside a necessary weight-promoting medication. Glucagon-like peptide-1 receptor agonists, also known as GLP-1s or incretin mimetics, are agonists of the GLP-1 receptor. This drug class is the newest and most aggressive medication treatment option we have for obesity to date. It slows gastric emptying and supports several metabolic processes throughout the body. Patients feel fuller, faster, and for longer. Nausea, sometimes vomiting, fatigue, and constipation are common complaints. Small, balanced, regular meals and snacks containing a protein and carbohydrate source may help alleviate the stomach upset. Liraglutide is an FDA-approved daily injection available for the treatment of obesity under the brand name Saxenda. The same medication is FDA-approved for the treatment of diabetes under the brand name Victoza. Dosing for the treatment of obesity starts at 0.6 milligrams daily for the first week, then advances to 1.2 the next week, increasing by 0.6 progressively each week until the maintenance dose of 3 milligrams is reached. Semi-Glutide is an FDA-approved weekly injection available for the treatment of obesity under the brand name Wegovy. The same medication is FDA-approved for the treatment of diabetes under the brand name Ozempic. Dosing for the treatment of obesity starts at 0.25 milligrams once weekly for the first month, then advances to 0.5 the following month, 1 milligram the next month, 1.7 after that, then the maintenance dose for that is 2.4 milligrams. The use of Topiramate alone for the treatment of obesity is considered off-label. It's indicated for binge eating, sweets cravings, evening snacking, and soda cessation. It slows brain waves, offering a calming effect that decreases emotionally driven urges to eat. It can make carbonation in certain foods taste off, aiding the patient with eliminating them. I generally start at 25 milligrams, even a half tablet in those concerned about side effects, and gradually increase as needed. The max dose usually for obesity treatment is 100 milligrams. Sometimes I might dose a little bit higher. Topiramate is available in a combination pill with Phentermine, which is an FDA-approved weight loss drug called Qsymia. Topiramate is a pregnancy category D, so it does cause cleft palate. Be aware it can cause kidney stones in patients prone to them. Aside from depression, Bupropion is indicated for binge eating, helps with those feeling a lack of energy, and offers some appetite suppression. I find it gives patients an I can do it attitude. It also helps with smoking cessation and somewhat with food cravings. It has a stimulant effect, so sleep, blood pressure, heart rate, and mood should be monitored. It is available in a combination pill with naltrexone, which is an FDA-approved weight loss drug called Contrave. Phentermine is indicated for appetite suppression. In my practice, I start with a very low dose and gradually increase as needed. It's available in 8 milligrams up to 37.5. The 8 milligram tablet is immediate release and can be dosed up to 3 times per day. The next dose up is 15 milligrams, then 30, then 37.5 is the max dose. The 37.5 comes in either a capsule or tablet. I start some patients as low as 4 milligrams once a day if they want to target maybe just a specific time frame that they're struggling with. I often prescribe the 37.5 milligram tablet so they can divide it and take half in the morning and maybe the other half later on in the day to prevent wear off for more seasoned patients. Phentermine does seem to lose its effect over time, so it's not helpful without sustainable behavior and lifestyle change. I will use it long-term for maintenance in some patients. Due to its stimulant effects, sleep, blood pressure, heart rate, and mood should be monitored. Naltrexone is used for cravings and drug and alcohol treatment. It also helps with food cravings. The use of naltrexone alone for the treatment of obesity is considered off-label. I start with a very tiny dose and gradually increase as needed to minimize side effects. Common side effects are nausea, headache, and malaise. I'll often start with a quarter tablet of the 50 milligram, which is just 12.5, and then they can gradually increase it as needed. I will dose up to 50 milligrams twice daily for some patients. Patients should stop this medicine at least 2 weeks prior to planned procedures requiring sedation or pain medication. So some common scenarios that I come across in practice, I will run through and give you kind of what the patient tells me and what I might consider for them. A patient might state, I eat a pretty healthy diet. According to my food journal, I get enough calories, but I still feel so hungry. I may consider intuitive eating, Phentermine, or a GLP-1. The patient may say, I eat well normally, but when I'm upset, I just zone out and eat anything in sight. I feel so ashamed of myself. I may consider diagnosing binge eating disorder and refer them to therapy. Vyvanse, Topiramate, or Wellbutrin might be good treatment options. The patient may say, I stay on track pretty well most of the time, but if there's chocolate in the room, it's over. I'm a chocoholic. I may consider naltrexone. I do well all day, but then when I get home in the evening, I just want a snack, salty, sweet, anything. It's just one little craving after another. I would start off encouraging that they eat adequate balanced meals throughout the day and maybe add a planned afternoon snack. A bedtime snack to look forward to might help as well. Medications I might consider are Topiramate or maybe a little smidge of Phentermine, 4 to 8 milligrams, just to get them through that rough time. They may say, I just can't get motivated to exercise or plan out my meals. I have time, but just can't get organized. I would consider referring to therapy. I would screen for ADHD, depression, anxiety, and treat accordingly. Treatment options would often be the Bupropion. Prozac would be a good weight-neutral choice for antidepressant. Our medical weight loss team recommends lifelong follow-up for our bariatric surgery patients. While less common after sleep, vitamin and mineral deficiencies can occur and can be serious. Post-op labs are generally checked at 3 months and the 1-year mark after surgery, then annually thereafter. While these labs can be completed by primary care, we do like to review them and update the vitamin regimen as indicated. Our dietitians work with patients to help find a vitamin regimen that works for them, and they'll assist them with finding them in stores or online. Behaviors for success are reviewed at post-op appointments to help the patient stay on track and avoid weight regain. Mental health issues may arise after surgery as some patients need help adjusting to a rapid change in appearance and lifestyle. The most common post-surgery complaints I see in the office are increased acid reflux, changes in taste and tolerance of certain foods, and bowel changes. Conservative treatment is generally effective. More serious complications with gastric sleeve are rare, but they can occur. These are some of my go-to resources to help guide my practice. I really appreciate all the referrals I've received thus far and look forward to working with all of you in the future. And I will now turn it over to Dr. Eibes.
Hey, everybody. So thanks again for having us. I've been doing bariatric surgery for 20 years and I'm pretty passionate about it. And I really think what sets a good program apart is the overall comprehensive team approach. Because if I do surgery and a patient is eating because they have food addiction or binge eating or they hate their spouse or they hate their job, I need a team to help with all of that. Or maybe they need medications to supplement their surgery. So it's very important. And like I said, I've been doing bariatric surgery a long time. I've done over 3,000 bariatric surgeries. The sleeve that we're going to talk a lot about, I've done over 2,200 at Iowa Weight Loss. I have a physician's assistant who has been with me 9 years, and we just do the same surgery over and over all the time, do follow-up visits, exercise, vitamin levels, that sort of thing. And again, everyone probably knows this, morbid obesity, body mass index over 40, all of the insurance companies will cover. If you're 35 to 40, they will cover. If you have diabetes, high blood pressure, sleep apnea, many of the insurances have now added osteoporosis, reflux, and Blue Cross will cover down to a body mass index of 30 if you have metabolic syndrome. And again, I used to joke that this was the greatest epidemic we're ever going to face, but it might be the second greatest epidemic at this point. But we have 2/3 of Americans are overweight or obese. We have 26 million Americans at least 100 pounds overweight. These are the obesity curves in the United States over the last 40 years or so, and you can see we're closing in on 40% obesity. What does that do to you? If you look at the diabetes rates, they're over triple. Heart disease is almost double. Cancer rates are almost double, if not triple. In fact, the main focus of the American Society of Bariatric Surgery National Meeting in June this year is going to be cancer being caused by the inflammation in your body from obesity. If you look at diabetes alone, it's the number 7 leading cause of death in the United States today. 90% of the type 2 diabetic cases are related to obesity, and we currently have close to 30 million type 2 diabetics. We have over 1 million new cases every year, and if you look at pre-diabetes, 80 million, it's slowly overwhelming the country. Heart disease, your rate of heart attack directly related to how much excess weight. 10% of our patients have congestive failure. 50% of our patients have high blood pressure by the time they're 100 pounds overweight. And again, the cancer rates are just escalating. The CDC would estimate we have 90,000 cancer deaths every year just to obesity alone. Respiratory, 70% of our patients have sleep apnea, whether it's diagnosed or not. So if your body mass index is over 40, You walk around every day with double the mortality rate as the average person, and if it's over 40 and you're diabetic, 5 times higher death rate. The estimates are we're causing 300,000 deaths every year just due to obesity, and we're decreasing life expectancy on average by 10 years when you're 100 pounds overweight. So that's why the Surgeon General came out and said, this is a crisis. We need to take action. We need to do something about this because 1 out of every 8 deaths in America is due to a disease that is affected by their overweight or obesity. Now, I always give this class to the patients, say, why are we getting heavier? Well, the food supply has changed. You know, in 1970 compared to now, we're eating almost 300 calories more a day. And your body, as we're going to talk about the hormones in a minute, is really, you know, thousands of years ago, you had to hunt or kill something for food. Well, now we have Pop-Tart. We go to any quick shop here, you have Pop-Tarts, cheeseburgers. We have very calorie-dense foods. And our physical activity has decreased tremendously. We have a knowledge-based society now where we sit at computers, we sit at desks, we're burning less than we used to. But what we didn't know about until recently is what really controls your appetite. Why are you getting heavier? Well, your stomach makes ghrelin, which is a hormone that is helping control your appetite, along with the pancreas, small intestine. And this mixture of hormones is really affecting your appetite, and that's what's making it very difficult for people to lose weight. Once they get at a certain weight, their hormones are geared to keep them at that weight, and it's much stronger and easier to keep them at that weight than the leptin and things to tell you that you're full and get you to lose weight. This is a graph of ghrelin that was drawn on patients. That bottom line is people before going on a diet, and you can see it goes up and down. Forgot to use which pointer here. It goes up and down during the day. By the evening, it goes up. They're hungry. They eat supper. It goes down. They're not as hungry. If you put these people on a 12-week diet and redraw their ghrelin levels, that's this top line. So you can see anytime, and I don't care what diet they go on, any diet that they go on, their ghrelin levels are going to increase, telling them that they are hungry. And it is very difficult. Most of the patients, when they're 100 pounds overweight, are going to need to diet for a year to get their weight under control. And when you're sitting here every day with ghrelin levels that are 500, 600 way up here, you're very hungry. It's very difficult to succeed long term. And that's why most of the patients, by the time they come and see us, they fail 20 different diets over and over. They've been dealing with this for 10 or 15 years. They feel like a failure. They're very beat down emotionally. They carry a lot of psychological damage from this. They're viewed as less intelligent. The disease is their fault. 90% of the patients by the time they come in are clinically depressed. Can't buy clothes in a normal store. Can they fit in the airline seat? It affects every aspect of their life. Our goal with surgery is just to give them a tool to get that appetite under control. They only really need me for a very short time to get their appetite under control, and then our team can work with them about making healthy food choices. How are you going to be successful? How are you going to deal with your relationship? How did you and your spouse eat before? How are you going to eat now? Now, when you look at the surgeries in the United States, lap band, sleeve gastrectomy, and gastric bypass are the 3 most common. Lap band has almost disappeared. It is currently about 1% of the weight loss surgery being done today. But I'll start with the gastric bypass. This is the oldest weight loss surgery. It's been around for 50 years. And with this surgery, you go up here at the top and you divide the stomach. You make a little pouch the size of a hard-boiled egg. So it doesn't hold a lot. You leave the rest of the stomach, the first part of the small bowel, and you divide it here and bring this loop of bowel up and reconnect it. So you've got approximately a third of the small bowel bypass, so food doesn't go through there, so you're not absorbing. And you see fantastic weight loss with this surgery. And the real reason I think you see the great weight loss, this is a graph, and this happens with the sleeve also. After surgery, this is their ghrelin level. When you depress that hormone level down and get their appetite under control, all of a sudden they can make better choices. All of a sudden they can eat 1,000 calories a day and be satisfied. All of these patients know what to eat. And most of your diabetic education patients have met with your dietitian 10 or 15 times. They know what they're supposed to do. But if their ghrelin level is sitting up here at 600 or 700, it's very difficult. If it's down here, it's just much easier for them. Now, like I say, this surgery produces 70% excess weight loss at a year. We calculate anything over a BMI of 25 as excess weight. So if they're 150 pounds overweight, 90 to 100 pounds would be average weight loss. But There's some problems with the gastric bypass. It is the most invasive bariatric surgery. We are rerouting the bowel. Things can happen with that. Complications can be severe, and they can happen years later. You can have severe vitamin deficiency, dumping syndrome, food getting quickly into that small bowel causing diarrhea, bowel obstructions. So if you look at some of the big complications, this is the Geisinger database that was presented at our national meeting, over 2,000 patients. If you look up to 5 years after a gastric bypass and you're looking at anemia, and we're looking at mild, moderate, or severe anemia, hemoglobin less than 8, 18% of the patients in this database had had an episode of severe anemia within 8 years after surgery. Even mild, you're talking 80%. So I think the vitamin deficiencies are very significant. And any bariatric program that's not thinking about this, I think you're underestimating. If you think that the patients are going to be following up 2 years, 3 years, 5 years later, these patients show up in their family doctor's office, haven't come in years, and all of a sudden they're sitting there with a hemoglobin of 8. So it's not inconsequential when you bypass that bowel. There's things that are going to happen, including B1, B12, vitamin A, all of these things. If you look just at bowel obstruction, depending on how you do the hookup, if you go in front of the colon, that's anticolic, antigastric. If you go behind, it's retro. If you look at the bowel obstruction rate, this is a meta-analysis over almost 20 years of 8 studies. If you go in front, the bowel obstruction rate's 1.4, behind it's 5.2. So I always tell patients, if I do a gastric bypass, I'm probably going to have a bowel obstruction rate of 2%. All bowel obstructions after a gastric bypass need emergency surgery to fix it. It will back up into the bottom part of that stomach and blow out that stomach. So you absolutely have to operate. Well, in this program, in the last 8 years, I've done 2,200 sleeves. I would have created 40 bowel obstructions. So that's a big deal if I had done that many bypasses. So I think about all that when we're thinking about what surgery should we do for these people. So that's why I only do the sleeve. I've changed a long time ago just because I think it has much better options for a couple reasons. With the sleeve, we put a calibration tube down, suck out the stomach, and I just staple and cut beside, and I just remove 70% of the stomach. It's a partial gastrectomy. We were doing these in the 1950s for a stromal tumor, a gastric cancer. We removed 70% of the stomach. In 1950, we didn't know. Why are they not hungry after the surgery? Well, now we know we're removing a lot of the cells that make ghrelin, so these patients are much less hungry because we're dropping that hormone level. We take the dilator back out. This remaining stomach is completely normal. Food goes through normal position. The opening into the sleeve is normal size. So when you put a lap band up here and you squeeze, trying to stimulate them to feel full, you're making a tight opening. So if you've seen any of those patients, they spit up, they have trouble. With a sleeve, stuff should go into that sleeve, but it's a much smaller volume. So they're going to feel full. So I always tell patients, I can tell you you're never going to have nachos again. You're never going to have a drink. You're never going to have a piece of pizza. You're going to have those things. But if you go to the Iowa State football game and you get some nachos, you're going to eat a very small plate of nachos. It's going to make you full with a small amount. But if I drop that hormone level down and they're just not hungry, the vast majority of the time, their appetite's under control. They do well. And when they decide to cheat, we have their appetite or their portion size under control. We are not touching the small bowel. We're not rerouting anything. The surgery's always done laparoscopically. 6 little incisions. On average, it takes me 45 minutes to do the surgery. They stay 1 night in the hospital. Some programs are pushing to go to outpatient. I don't really believe in that because there's too many people, if they need some IV fluids, if they're spitting up, I think they'll be in the ER too much like that. So we keep them overnight. The next morning, we let them drink for a while. They usually go home by noon. We're suppressing their hormones, controlling their portion, no rerouting. And I always tell patients this is huge because down the road, all of the medications that Rochelle talked about work even better after the sleeve. When she talks about using a GLP-1 and slowing emptying, if we do that after a sleeve, it's almost like their sleeve is brand new. So I think the future will be, let's say with a sleeve, we get 60, 65% excess weight loss. If we add a GLP-1, we might be at 90% weight loss, or at least it gives you options if they gain weight down the road. And again, it's much easier long-term care. I think no matter what you do, certain patients are going to fail. If you failed a gastric bypass and you're sitting out 15 or 20 years, you still have a bowel obstruction risk, you still have vitamin deficiency, and your weight's not under control. With a sleeve, you're hooked up normally. So even if you don't listen to anything I say and you're going out drinking every night with your friends and you gain your weight back, you're hooked up normally, and your vitamins, everything is much easier for your family doctors or wherever you're going to take care of. Now, Ghrelin reduction. This is a study done on sleeves. 12 patients were followed for 5 years. Before surgery, their average Ghrelin was about 600. 5 years later, it was still only 257. So if we can maintain that appetite suppression 5 and 10 years later, that's crucial. That's how you're going to be successful. So compared to the other surgeries, compared to the lab band, we just don't have any plastic, any tubing, any foreign bodies, much better appetite suppression, much lower weight rates of reoperation. And compared to the bypass, you know, there's a push among some surgeons to keep doing a lot of bypasses. I just think you got to really think about the vitamin deficiency and the bowel obstruction rate. It's been a great surgery over a long term, but the sleeve just has a lot lower risk profile. The sleeve is lower risk than having your gallbladder out. So when you think about that and some of the cure rates for diseases, it really kind of changes the world for most patients. And if you look at the big data, I love data. So this is one of the big studies out, the Utah Adams study. Over 7,000 surgery patients compared to 7,000 dieting patients followed for 7 years. If they had surgery, their death rate dropped by 40% per year, diabetic deaths by 92, heart disease by 56, cancer deaths dropped by 60%. And again, I think I've already hit all of this stuff. I'm kind of jumping around the slides here. Most of our patients back to work in 10 days. We do a liquid diet afterwards just because the sleeve is a little bit narrow and irritated. They're back to solid food within a month, and within a month they can exercise. Now, this is our data. These are our patients from 2016 and 2017. We run all kinds of databases on these things. During that 2 years, we operate on 562 patients. They started at a BMI of 46. And this is 6 months, a year, 2, 3 years later. Now, this is, again, we try hard to get everyone to follow up with us forever. I don't believe in graduating patients. I think they need a yearly follow-up. I think they need to touch base with our team and work with us long term. But even then, even with phone calls, letters, all this, only 61 following up. But their BMI drop is still 13. Their excess weight loss is still over 50% of their excess weight gone 3 years later. This is our complication rates. 2,200 patients over 8 years. We've had 4 leaks, 3 blood clots, 8 bleeds, 3 portal vein. The 2 mortalities we had, both autopsies, were completely normal. They could not find anything. One had a history of arrhythmias. The other had a family history of sudden deaths after surgery. We could never find anything. They both just suddenly died about 10 days after surgery. So, but as far as leaks, blood clots, things, it's exceedingly low complication rates. And if you look at our MSQIP database, this is our national database with over 30,000 patients that have had a sleeve. Again, here's the national numbers. Again, compared to living with diabetes, high blood pressure, sleep apnea, by far safer to have surgery. And if you look at band bypass and sleep, I would argue that these are some of the most studied surgeries in the United States today. We have a national database. Every center of excellence has to put every patient in the database, and we follow all these complication rates. The chance of dying is exceedingly low. Leak rates are exceedingly low these days. Now, here's what's happening in the United States. In 2018, we did 252,000 surgeries. We have nearly 30 million people that qualify. And again, 60% now sleeve, 17% is bypass, and the rest is these other rarely done or revisionary surgeries. A lot of the revision is removing lap bands and things that we've had problems with in the past. Long-term data. All of these studies have smaller numbers of patients in them. I know it's a little difficult to get people to follow up 6 years, 5 years, 8 years later. Here's their weight loss, though. Still over 50% way down the road. I'm sorry, my slides are a little off center here. This is a randomized trial looking at sleeve versus bypass. The 1-year weight loss difference was 7%. When I see studies like this, I'm not sure it's worth the added complications of a bypass for 7% better weight loss. So that's why for nearly 10 years now, I've been doing only sleeves. I talk about all the options. If people want to have a bypass, no problem at all. The university can do them, that sort of thing. But I think there's just a lot of issues and things that can happen. Now, I chose to focus a little bit on diabetes here. We have a massive amount of research on diabetes, well over 600 studies. If we do bariatric surgery, the remission rate of diabetes at 1 year is 78%. At 10 years, it's still 40 to 50%. The Stampede trial from the Cleveland Clinic, kind of a landmark prospective randomized trial. 50 patients were randomized to medical weight loss, 50 to sleeve, 50 to bypass. They were followed for 5 years looking at hemoglobin A1C levels. If you were in the medical group, getting your A1C less than 6, 2 out of the 50 achieved that. None of them were able to do it without medications. The bypass, 14 of them, 29%, had an A1C less than 6 with meds. 11 were off all medications. And the sleeve, again, 11 with meds, 7 without meds. So it's at least worth having the conversation with them. Insulin use in this study. In the medical group, 5 years later, 40% were still on insulin. In the surgery group, 12% were on insulin. And this is one of our longer studies. This is 6 and 7 years after sleeve gastrectomy. In this study, excess weight loss was 65% or so at 7 years. Again, in this same study, here's the number of patients 7 years later that had complete resolution of diabetes, high blood pressure, sleep apnea. I always tell patients when they come in, the weight loss is really kind of your side effect. I'm treating diabetes, high blood pressure, and sleep apnea, heart disease, things like that. You're going to look better in your clothes. You're going to feel better. Your joint pains are going to be better. But we're trying to treat all these different diseases. And this is a bigger study, Cleveland Clinic, looking at age-matched medical patients versus metabolic surgery with an 8-year endpoint. In the surgery group, if you combine all of these cardiovascular events that can happen, the rate over 8 years was 30% in the surgery, 40% in the medical group. Chance of dying over that time, 10% in the surgery versus 17% in the medical group. That's why it's led to a lot of changes. There have been 75 medical societies now that have endorsed bariatric surgery for many of these things, particularly diabetes is the big one. Because if you're diabetic, you should diet for 6 months, 9 months. And I tell people if they have any doubts, any questions, work with our medical team. If you work with our medical team of experts and if 6, 9 months you're still diabetic or have high blood pressure, it's time to at least have the discussion about surgery. And this was published about diabetes and surgery-related diseases. The big one, this was Dr. Cephalou, who was the chief science officer of the ADA in 2019. And again, his last line, metabolic surgery has proven to show improved glucose control and homeostasis more effective than any known pharmaceutical or behavioral approach. So, and I could present data on sleep apnea. 59%, the database out of England, 59% of sleep apnea was cured at 1 year, 50% of hypertension. So, and all of that data is readily available. So I tried to keep mine short for questions. I'll start with a whole bunch of questions that I get asked all the time. I thought we'd just start with these because these are very common. The top one on the list I get asked all the time. Can we do bariatric surgery here in Ames? We absolutely cannot because it is not certified as a center of excellence. Years ago, there were lots of complications with bariatric surgery. Some of you remember 15 years ago in Des Moines, there was a lot of issues and deaths and problems. The ASMBS has very strict criteria about becoming a center of excellence. It is very difficult. All of the insurance companies require the patients to be done at a certified center of excellence. Our hospital in Belmont is certified. We can have satellite clinics for the medical weight loss. The surgery has to be done there. In order to qualify, we would have to do 125 surgeries here before we could apply. They would all have to be cash pay patients because insurance wouldn't pay for them. So it'd be very difficult to get to that point. Who qualifies? Again, body mass index over 40. Everybody qualifies, 35 to 40 with an accepted comorbidity. And again, diabetes, high blood pressure, sleep apnea are the big ones. How do we know if insurance covers? Every patient that comes to us, I have an insurance team that helps them. We take their coverage, we call, and we get all the data. Many times they are told by their insurance company on the phone they have coverage. We don't buy any of it until we see things in writing, and our whole team will work with them. Another big one, what's the rate of weight regain? After surgery, 5 years later, 50% of people will maintain all of their weight loss. 50% will gain back. All of those patients will say that their surgery's failing, it's not working right, things like that. The reality is, I personally don't think more surgery is the answer. Most of these patients, when you look at why are they gaining weight, well, they hate their spouse, so they're eating to deal with stress. They have ADHD, they have bipolar, they're treating their mental health issues with food. They're going out drinking with friends, things like that. Or maybe their other hormones, their pancreatic polypeptide, their leptin are upregulating their appetite. Maybe we need to add medications. So when people regain weight, they need to come back in and work with our team. I mean, obviously, if they have a mechanical problem with their sleeve or something, that's fine. But the vast majority just need our team to work with them. Every patient that has come back and told me that their sleeve has dilated and stretched, I can do a CAT scan volume study and check it. The normal stomach is roughly 1,200 to 1,600 cc's. When we're done with a sleeve, we like it to be 150 to 200. I have never seen a CAT scan volume study larger than 400 afterwards. So it's dilated a little bit, but if it's still 1/4 the size of your normal stomach, I have a hard time. But you really start talking to them, well, yeah, they might be drinking 2 glasses of wine every night. They're eating some ice cream at dinner. There's other factors in there. How do we manage the psychiatric care? We have a large psychiatric team. The pre-op evaluation is just to make sure that it's safe for them to have surgery. Schizophrenic, somatic disorder, things like this, we will select out patients that it's unsafe for them to have surgery. We will do bipolar patients and some of these other things, depression, PTSD, if things are under control. So that's really, and it's very few that we turn away. But I think the real crucial thing is they need help down the road. Most of these people have been discriminated against, treated badly for a long, long time. And I can control their appetite. And it's almost impossible for the medical team to have success until I control their appetite. But once I get that, then the psychiatric team can start attacking some of these other issues. We commonly have people come in too with, say, severe binge eating disorder or an addiction, something like that. Maybe they're drinking a 1/5 of whiskey a day. We'll treat that first. And then after we treat that for 6 months or a year, when they're ready, then we'll go on to surgery. What's the role of exercise? Absolutely should be exercising. We're working on increasing that. We have an exercise coach in our program, and we kind of meet them where they're at. And we have some people that can barely walk. Some people go to Referral. Some people go to CrossFit. Some people go to Lifetime gyms, all this sort of stuff. So it kind of depends on where they're at. Most of them, we encourage, just start slowly, start easy with walking. But once they get 30, 40, 50 pounds off, then they can exercise. Then they can push themselves. We have people running 5Ks. We have people doing all kinds of things. The other big secret I tell patients, the most important thing is weightlifting. I know it might sound crazy. I tell them, you're not going to be Arnold Schwarzenegger, this sort of thing. But when you're carrying around all this extra fat, as you lose weight, you're not carrying the fat anymore. You're going to lose muscle. I will put them in a calorie deficit for sure immediately after surgery. If they will lift weights and stimulate the muscle, they will retain muscle and burn almost pure fat. If you do too much cardio, if they're doing cardio 5 or 6 days a week, they're going to lose fat and muscle. So our team will look at that, and that's where the metabolic rate, the SEICA scale, all of this, we're calculating what's their muscle mass, where are they at, kind of making adjustments to that. Is there a role for lap band? I hate the lap band. I think the lap band causes an eating disorder. I have done 500 of them years ago. I've stopped a long time ago. When you're squeezing on the top of that stomach, eventually, we didn't realize 20 years ago, your stomach's making ghrelin that's controlling your appetite. So if I squeeze and I give them a full sensation, they'll eat less. Their ghrelin level goes sky high. And now we're playing a tug of war. How tight can I squeeze? The tighter I squeeze, the more soft their food has to be. Soft food, they end up eating lots of carbohydrates. They decrease their protein. And we basically cause an eating disorder. So I haven't put bands in. I remove one band probably every month or so and convert them to sleeve. Now, the last one I have, this is the big topic. What about reflux? This is the most controversial area in bariatric surgery right now because the sleeve is a little bit narrow. So it will be a higher pressure, so it can increase reflux. 20, 30% of the time, we might make reflux worse. 20%, we're going to cure reflux. The rest is indeterminate. So there's a movement that how much pre-op evaluation do they do? And there's a push to do EGDs, pH probes, esophageal manometry on all of these people to see where we're at with this, because if they have significant reflux, should we talk them into a bypass? Because the bypass, when you divide it, is probably a little bit better at controlling reflux. I have a couple problems with that. When you look long-term, 10 years after a gastric bypass, they have a 50% reflux rate. It might be bile reflux, but a patient will say they have reflux symptoms, so it's not clear whether you're curing the reflux. There's concern that the reflux could cause Barrett's, could cause cancers, and are we going to generate a whole bunch of esophageal cancer with a sleeve? Maybe, but there was a big meta-analysis done showing an 8 times higher cancer rate after a gastric bypass. So I think a lot of that is probably we're taking Barrett's patients, putting them into bypass because we think that's the better thing. They're high risk, but it's not really clear. So I just think you got to think about the complication rate. When you're looking at the bowel obstruction, the vitamin deficiency rate, maybe the bypass is a little better for reflux, but you're having all these other spin-off complications of it. I always tell patients, if I do a surgery, if I do a sleeve, I might make your reflux really bad. And down the road, it could be terrible. But in the solution to that, a sleeve can be converted to a bypass. You just cut across the top of the sleeve and make it into a bypass. In the last 8 years, 2,200 patients, I've had 6 that needed converted. And the last 2 that I sent to the university that were converted within 6 months had severe reflux after their bypass. So I'm a little old school cautious about rushing into a bypass and rushing into lots of complications. I just explain to them because it's unpredictable, because just as much chance I might completely cure their reflux with a sleeve, we just don't know. So that's kind of where I'm at with reflux, and I discuss it with every patient, and we can do all that testing if they have really bad reflux, but kind of leave it at that. So that's all I have. If anyone has questions for me or Rochelle, we are happy to answer anything.
Hi, do you have a lower age limit for all of this, adolescents or even 5-year-olds that are morbidly obese?
Yep. So there's a rule in the ASMBS. You have to be designated as a pediatric center of excellence to do surgery. You have to have a specific pediatric ICU and all these protocols, and we don't. I don't believe the University of Iowa is doing kids. In the past, it'd only been you had to go to Chicago as far as surgeries.
Grinnell was.
Grinnell.
Last I knew, Grinnell was doing kids. Dr. Paisley in Grinnell, but she is moving out of state, so I don't know who will be taking over her practice for sure for that. As far as medical weight loss, I'm family practice. Some of our other providers are adults, so they will not see kids. I will see kids cautiously and then refer them on if it's something complex.
It's easier. We could do some meal planning. We can do some of the stuff. It's debatable about what to do with the medications. It'd be great if we could get it under control before they get to the point of needing surgery.
Yeah.
But we can start broaching the topic because we see kids. There's a ton of data outside of the United States on kids that are 15, 16, 17 years old with BMIs of 60 doing fantastic with surgery. But in the United States, it's very strict guidelines to do it. Go ahead.
So for the different surgeries, is there a different rate of decreased bioavailability?
Is there anything in the chat?
Most of the medications are absorbed in the small bowel. So even the long-term sustained release stuff, we really don't have a problem with that. I mean, we follow the vitamin levels and things are the big things. So we will at 3 months check levels, and then once a year. After a bypass, you check levels every year for the rest of their life. After a sleeve, it's debatable because after 1 or 2 years, if they're stable, are they going to be fine? Is a full set of vitamin levels is like $1,300 or $1,400. So it's debatable whether we should recheck them. But otherwise, medications and stuff, we don't make adjustments after a sleeve, like if they're on some long-term sustained release. No problem.
Nope. Yeah, and since the stomach is smaller, I mean, we do see, as far as low vitamin values, the most common that I see are like B12, vitamin A, iron deficiency. So also long-term use of PPIs after surgery will decrease some absorption as well. So it's kind of give and take, but we supplement as needed. And then we have our dietitians on staff that can help them formulate a supplement plan. But yeah, other medications, I haven't seen any problems with absorption, at least with the sleeve for sure.
I guess I should qualify. I think of sleep. If you're thinking bypass, absolutely, there can be problems, especially if people are on Coumadin or something like that. It is really hard to manage because they're kind of all over the place, depending on they're having a good day or bad day, how much are they spitting up or whatever. So that used to scare me to death when people would come in and all of a sudden their levels are just all over the place with it.
For those of you online, you could enter a question into the chat. Just check quick here. Still nothing.
Yeah, but while we wait for questions to come in Ames, here I am here Monday through Friday, 8 to 4 generally. You can swing by the clinic if you have questions or anything. Again, we're next to the sleep lab now on the second floor right below rehab. You can swing by and pick up brochures or business cards if you need them anytime, or you can email me. It's just my first name, last name, Rochelle.Mccabe@iaspecialty.com. And that's on my business card up there as well. But yeah, or you can call the main number and they can put you through to me too.
And I think we try to make it very easy for patients or for you guys as referral docs because it's very difficult. I mean, it's hard for you in a family practice office to have an hour to sit down and talk to somebody about exactly what type of calories you're eating. And we don't use like one type of meal plan or something. We customize towards every patient because we have people walk in drinking 12 cans of pop a day. Or we have one that will only eat chicken nuggets, or we got all kinds of things. And you've got to adapt to this. We have people that have tried keto and failed. They want to talk about intermittent fasting. So we really got to get a handle and individualize what works for them. And that really starts by looking at a food journal. What are they eating? Maybe do a metabolic rate test. Every patient tells me they have a low metabolic rate. That's their problem and whatever. It's something like 5% of people really
Yeah,
do.
and I think the misperception with that too is when we do the metabolism testing, for every person, their caloric range is different. And so they assume they have a low metabolism, but say 1,500 calories for patient A may be too much for patient B or might not be enough for patient C. So you can't have just a one across the board calorie, like 1,200 is a weight loss diet is different for every single patient. So that one patient you're giving 1,200 calories, their minimum body requirement without being in like a starvation zone might be 1,400. So then you're starving them. All those hormones are just going to fight so much harder. They're going to be miserable. But if you move them up to 1,400, they'll be more comfortable. We can control their appetite with meds a bit. It's a little easier that way. We're not fighting so much. And they'll have great results just the same. So,
And we want something that's sustainable. I mean, I don't think it's realistic to go on a ranch like The Biggest Loser and live there, and this is how you're going to lose weight. I mean, we got to figure out how are these people going to live for the next 20 or 30 years. And so that's why we try to stay away from supplements and things like that. I mean, it's great to take vitamins, but to think that you're going to take Optifast forever for the rest of your life, that's unrealistic.
yeah, I have a lot of patients who come into her like, I just need a jump start, something to get me going. That's not real life. I mean, real healthy, sustainable weight loss is hard work. It's making a lot of dietary changes, changing your activity. It's going to be slow. We tell most of our patients we want to see 1 or 2 pounds of fat loss per week. That's healthy. And a lot of them are looking for, I need to lose 30 pounds in the next month because I need to fit into my swimming suit. And it's like, that's not healthy.
Well, and then the next thing they tell you as well, they're eating because they really are in an abusive relationship and don't want to look good to the opposite sex. And so it gets a lot deeper then, and that's where we really need to intervene because until we confront those problems, they're not going to be successful long term.
Yeah. We do have a patient on occasion that comes in and there's a lot of red flags underlying that are just weight loss is probably not the first step. So we make those referrals for them too. Yeah.
Is plateauing an issue?
So as far as with medical weight loss, patients will so-called plateau. If it's been like a year since their last metabolism test, we will retest it and make adjustments because it'll change with weight loss too. A lot of times it's just bumping up a little bit of exercise, maybe increasing strength training and such. But I do see weight loss kind of cycle. Like I'll have patients who will have a great weight loss and then for 2 or 3 months, nothing. Then they'll have a great weight loss and then 2 or 3 months, nothing. Your body really wants to fight weight loss because it views fat as a slow burning precious fuel. The more the merrier. It does not want to give it up. So once your body feels like nutrition's coming in, maybe it's building some muscle, it's feeling good, it'll let go of some fat, but it does kind of cycle and it goes in spurts. It's not a nice, slow, steady line. Yep.
One thing we always talk about too is keeping it in remission. We almost talk about like cancer. I mean, they still have the same tendencies. I mean, we'll suppress their appetite, but they still have this tendency. And that's why I think it's important to work with them long term. Because even if I've done their surgery and their weight's been under control for 10 years, now they go through a divorce or something else. We need to work on all of that to keep them healthy.
Yeah, and it really is an ongoing thing. It's not like we get to this one point and we're done and they're cured and it's good, they move on. It's an ongoing, ever-changing process. So yeah, some people are just more prone to weight gain for one reason or another. There's a lot of studies going on right now, a lot of science we don't even understand. The GLP-1 is the newest med, the most revolutionary thing we have, and there are a lot more studies and things in the works. We just haven't quite gotten there yet.
Tim says there's nothing in the chat, so thank you very much for your talk. It was very interesting.
Very
Thanks,
good.
everybody.
Thank you so much.